Move to the next talk. The next speaker is Dr. Pascual Sánchez-Juan. He is a neurologist at the Marqués de Valdecilla Hospital in Santander, and he is an expert has worked on Creutzfeldt-Jakob disease, genetics, and an expert on neurodegeneration. Thank you.
Thank you very much. Okay, good morning. I'm going to talk about molecular imaging in dementia, but from the very clinical point of view. As you know, early onset dementias are a clinically challenging group of diseases, especially because diagnosis is made by clinical history, and the main role of diagnostic tests that we have is to rule out non-neurodegenerative diseases like inflammatory vascular tumor. So, definite diagnosis in neurodegenerative diseases requires neuropathology, and in our patients, brain biopsy is most of the time not an option. So we urgently need biomarkers that allow an early and accurate in vivo diagnosis in our patients. Biomarkers will increase the clinical confidence in the diagnosis, which will decrease the diagnostic test performance of the patient and will save money, will improve treatment selection, and hopefully once we have effective treatment will allow an early start of the treatment, and very important for the patient and the family, will allow an accurate and realistic prognosis. So CSF biomarkers are probably very well established as biomarkers, especially for Alzheimer's disease. A-beta 142, tau, and phospho-tau are part of the proposal of research criteria. But despite of big international efforts to harmonize protocols, we still have some problems of some reproducibility issues, and lumbar puncture for some patients and also from some physicians could be also an issue. So nowadays, CSF biomarkers testing are limited to research, and they are mainly performed in academic centers. Additionally, other diseases like frontotemporal disease spectrum diseases, which are an important differential diagnosis in early onset dementia, we do not have CSF biomarkers which are currently available for these diseases. So I'm going to focus in my talk in molecular imaging biomarkers. In 2004, the first molecular imaging biomarkers, the FDG PET, which is showing us how the glucose metabolism is in the brain, was approved by the FDA for the diagnostic evaluation of dementia. Actually, it was meant to differentiate between frontotemporal dementia and Alzheimer's disease. That was the main indication. And as you can see, it makes a lot of sense. This is normal control. This is an FDG PET showing glucose metabolism. This is a normal distribution of glucose metabolism, pretty much in the cortex and also basal ganglia. Here we see an Alzheimer's disease patient with a classical pattern, which we see an hypometabolism in the temporoparietal areas, and also the posterior cingulate and precuneus. So very posterior hypometabolism. And when we compare to frontotemporal dementia, you see that it's quite different. In frontotemporal dementia, we see an anterior pattern of hypometabolism. But the biggest step forward in this field was also in 2004, when PIF-PET and a tracer that was able to bind to amyloid, to beta amyloid, was available. PET scan using PIB is very specific and sensitive to detect fibrillar A-beta plaques, so it allows us to see in vivo the A-beta plaques. And since the original description in 2004, there have been many studies trying to address its discriminative power between different groups of diseases. This is an example of the literature. PET-PIF is helpful to discriminate between healthy controls and Alzheimer's disease patients. It's also helpful to discriminate those atypical Alzheimer's disease patients. Also help us to predict the conversion from mild cognitive impairment to Alzheimer's disease. It's also very good in the differential diagnosis between Alzheimer's disease and frontotemporal dementia, a disease without beta amyloid deposition. And it's also helpful to differentiate Alzheimer's disease from vascular dementia. PET-PIP is not that helpful in distinguishing Alzheimer's disease and Lewy body dementia or Parkinson's disease dementia because of the copathology that is so frequent in these diseases. And it's not that helpful monitoring Alzheimer's disease progress. So PIP is not helping us in that. And it's also not helpful correlating with areas with decreased metabolism symptoms. We do not see a good correlation between, for example, FDG PET and PIP deposition. But the biggest problem that we have with PIP PET is that is hampering the clinical utility is the fact that the half-life is very short. It's just 20 minutes, which just this tracer can be only performed in academic center with a cyclotron, so it's not really meant for clinical practice. But to overcome this problem, new F18 compounds that also binds fibrillar A-beta are now available in the market, and 3 of them have been approved for clinical use in the US and in Europe. The problem of these compounds, and they are actually very expensive. Not only new amyloid tracers are now available, now it's very exciting that in the last 2 years, tau tracers have been developed. And these are some slides from Gil Rabinovici from UCSF that is working right now in one of these tracers. The 2 more promising tracers are PBB3, a compound that was synthesized by Makoto Higuchi in academic center in Japan. And the other one is this T807 from Lilly. It seems that the compound from Lilly is technically easier to handle because it's biologically more stable than the PBB3. So I'm going to show you a couple of examples of these tracers in Alzheimer's disease patients. This is a patient with posterior cortical atrophy variant of Alzheimer's disease. As these patients have a predominant visual symptoms, and normally they are affected the posterior areas of the brain, the occipital and the parietal. And you can see here the amyloid PET showing a widespread distribution, similar to what we saw before. And this is the FDG PET showing the metabolism, which is telling us that the problem is in these posterior areas of the brain. So we don't see really matching the position of the amyloid and the hypometabolism of glucose. So, and this is an image of the tau PET. As you see that the uptake of this tracer is really mirroring the defects that we find in metabolism. But of course, we can also use these PETs to scan pure tauopathies like PSP. This is an example of a PSP. And we can see the dentite nucleus of the cerebellum, the uptake of the tracer. Also we see in the nigra, and also we see in the basal ganglia, as we would expect in a PSP. But we are coming back now to the amyloid tracers. As I said before, the new compounds for clinical use are quite expensive. So in last year, it was an advisory panel that decided that Medicare shouldn't pay for these studies based on the information that they have available. And the thing is that there have been plenty of studies, as I said before, trying to discriminate between different syndromes, but few studies have addressed the utility of PET amyloid tracer in clinical practice. So how these techniques are helping us clinicians to do a better job with the patients. Additionally, patients in these studies are selected from reference center based on inclusion and exclusion criteria, so it questions the external validity from these studies to our everyday setting. in this same line, last year also, it was a panel from the Nuclear Medicine and Molecular Imaging Association trying to recommend a rational use of these compounds. And they got to the conclusion that patients with MCI, patients with atypical dementia, and patients with early age would be the main three groups that would benefit from these studies. But again, this was based mainly on the opinion of experts, very theoretical, but not based on empirical data. So in order to address this issue, we decided to make a naturalistic review of the case records of the UCSF Memory and Aging Center patients that have been studied with FDG PET and PIP PET. So basically what we did was to evaluate longitudinally the course and clinical decision making in these patients that have done both examination at the same time, PET PIP and FDG PET. So we identified 140 patients that underwent a study because they were cognitively impaired. All of them underwent PIP PET and at the same time FDG PET. They were young patients, as an average 65 and 46%. The primary diagnosis was amyloid beta, so this is not representative for the rest of the group. This group is very interested in frontotemporal dementia, so this is probably in one of our clinic, the primary diagnosis, amyloid beta, would be much higher. And they were relatively at early stages. The mean mini-mental state examination is 22.3. So what we did is to assess the changes in clinical practice between the pre and post-PET clinical examination. So we assess how many of the patients changed from an A-beta diagnosis to a non-A-beta diagnosis and vice versa. And we also assess the treatment plan changes. So which drugs, Alzheimer drugs, were removed or were started. Well, and the first thing that we wanted to study was the PET concordance with the clinical diagnosis. This is very important because that's if the result of the PET is very concordant with what the clinician was thinking, is not adding really new information. I mean, it could increase your clinical, it could reassure and can give you more security of your diagnosis. And this could be positive because this could be reduce the number of tests that you are going to perform, but it's not adding real new information. So we were especially interested in see the discordant results. And we saw in this setting that the concordance between what the clinician was thinking and the result of the PIP was very high, 84.3%. So they both agree in most of the cases. And also for FDG PET was also very high, 82. But this is the whole picture. It is very interesting to see what happened when we go to the different syndromes. So in this graph, you see the black bars is the concordance with PIP, and the gray bar is the concordance with FDG. So we see that for some groups, the concordance is not that good, especially the rare variants of Alzheimer's disease, like Alzheimer's disease, the frontal variant, or corticobasal syndrome is a disease where you have a lot of different underlying etiologies. In these atypical cases of dementia, we saw that the discordance was higher. Of course, one of our most important goals was to assess changes in treatment. The primary diagnosis changed after PET in only 13 out of 140 patients, so just 9.3% of the patients, so quite modest. But when we saw the changes, most of them were concordant with PIP, 12 out of 13, and also 8 out of 13 were concordant with the results of FDG. So we can think that the result was driving this change. But in order to see more clearly what clinical factors were affecting the decision of the clinician to change the diagnosis, we analyzed all these different clinical factors, and we saw in the univariate analysis that the discordant with the clinical syndrome of the PIV result discordant and the FDG discordant with the clinical syndromes were the most significantly variables associated to a change in diagnosis. So that were the things that make the clinician change the diagnosis. But when we put together all these variables in a logistic regression model, we saw that only PIV was still significant. So it seems that the clinicians trusted more PIV results. To understand this conclusion, you have to see this table. This is the distribution of the patients that changed the diagnosis according to the different results of the PET scan. Here we see that when the FDG was concordant with clinical impression and the PIV was also concordant, in just one patient, they changed the result. And this is because this patient turned out to have a C9 mutation, so it has nothing to do with PIV. So no changes. And the opposite, when both are discordant, PIV and FDG, in most of the cases, the clinician decides to change the diagnosis. But when you go to the cases where PIV discordant and FDG was concordant to the result, in 40% of the cases, the clinician followed the PIV and didn't give that value to FDG. And the opposite, when FDG was discordant but PIV was concordant, the clinicians all followed the PIV and they didn't trust the FDG. The other important outcome was treatment changes. The changes in treatment were also modest in our series. And basically, we only found significant changes in treatment only for PIV, not for FDG, and in patients with non-A-beta diagnosis. So FDG had no impact in AD treatment, and the impact of PIV was only moderate, and to those patients that the clinician was thinking that was not A-beta, but the PIV was positive, then decided to put Alzheimer's disease treatment. So the conclusions for this study, the UCSF assessment, well, one of the things that was striking is that the high concordance between the initial clinical diagnosis and results of both tests, PIV and FDG. So telling us that they are not really offering much new information, at least to this clinical setting. But it was interesting to mention that that for some atypical syndromes, the discordance was higher. So these atypical syndromes may benefit more for this test. And also the changes in diagnosis was also modest, and as mentioned before, only restricted to some subtypes of patients that have initially not an A-beta diagnosis. And again, the PIV was a stronger impact than FDG. So when we finished this study, my question was, how can we extrapolate these results from a big reference center like UCSF Memory and Aging Center to the rest of our memory clinic? And in order to answer this question, we are also in my hospital, we've been performing FDG and PIV PET since 2010. We already have 127 patients with both tests performed. And our intention now is to perform the same analysis in our Santander memory unit. This work is still ongoing, so I'm going to show just some preliminary results. The description of our patients is similar to what we found in San Francisco. Basically, the patients that we include were those that we thought as a clinician that would benefit from the test. So this is the main inclusion criteria. And of course, most of them are young. So the mean age of onset is 63. and they are also in an early stage of the disease. The mini-mental state is 25 as an average. So what I have analyzed is the difference in the discordant PIV results. As we saw before in the logistic regression model, the discordance between PIV results and the clinician impression is the most significantly driving variable to change in diagnosis. So if we remember what we found in San Francisco, which is 15.7, the discordant PIV results in Santander is more than double. So we would expect a higher impact in our series compared to in San Francisco. Possible explanations? Well, first one, that they are much better clinicians than us. That's probably true, because they are probably the best center in the world. But also could be that our patients are different. And well, both are young and both are studied in early disease stages. Probably they have a different scope of patients. They are focused more on frontotemporal dementia. Our clinic is more general neurology clinic. But I want you to focus on, this is the distribution of syndromes in the UCSF patients. And just want you to focus that the amnestic MCI and non-amnestic MCI group is very small. So they don't use this concept a lot. So, or the patients probably, because they don't go to a different protocol, or they didn't have many patients with MCI in their series. However, in our series, this is our series, in green are the MCI patients. We have a lot of MCI patients. We use it as a working diagnosis, the MCI concept, especially in young people. And this is our data again. We see that most of the discordant PIV results are in the group of amnestic MCI. I think this could explain a big part of these differences in PIV concordance with diagnosis. So, as a final conclusions, well, I think we have to say that PET FDG and especially PET PIV are useful diagnostic tools in early onset dementia. And we can say also that these results, although might vary considerably, seem to be applicable to different clinical settings, very different clinical settings. But I think it's important to know that our results do not support a generalized use of PET FDG and PET PIV in dementia. There must be restrictive, especially taking into account that these tests could range from 3,000 euros to 1,000 euros, depending on the center. So they are very expensive. So, and our data is in line with the appropriate use criteria for amyloid PET guidelines that it was launched last year. And we should focus on atypical forms, and we should focus on MCI, especially in young patients. I think that would be the take-home message. And just to finish, to acknowledge my people from the Unidad de Deterioro Cognitivo, the Hospital Marqués de Valdecilla, also my friends from the Memory and Aging Center at UCSF, Bruce Miller, and especially Gil Rabinovici, and also the head of the nuclear department, Jose Manuel Carril, which is the magician that performs the PIV in our hospital. Thank you very much.
Thank you. Thank you for your talk. We have time for 1-2 questions.
Yes, you told us the difference between USF and Valdecilla. And I think that probably is due to the different patients. I think that Valdecilla has fantastic clinicians, no problems. My question is, have you tested people with familiar Alzheimer's disease, or you have only worked with, are you only working with sporadic people?
Yes, sporadic. Yeah.
And in USF?
Sporadic. Yeah, the population is sporadic.
It's sometimes when you compare something with the disease with familial origin, let's say frontotemporal diseases, with some people that it's only sporadic diseases, you can have also differences. Do you not think that that difference will be the answer to the analysis found in USF and in Valdecilla?
Sorry, can you repeat?
If you have, for example, a lot of people with frontotemporal dementia that here or in USF that are from
The same family.
familiar diseases, and you compare those with people with Alzheimer, sporadic disease, could be perhaps some part of the answer of the difference that you find in both places. That, well,
You mean with tau tracers or?
oh yes, I think also tau tracers are really good tau tracers.
Yeah. They work fantastically. And they still have some technical problems. They see some signals in controls that shouldn't be there. They see signals in the nigra and striatum that they don't know what the meaning, but technically they are doing a pilot right now with 27 patients with different tauopathies and Alzheimer's disease, and it works very well. Those slides just are from patients from recently, yeah.
Congratulations for your presentation. Thank you very much. And I am only one question about the clinicians, as you suppose. How many are follow the MCI patients in your sample? For how long? For 1 year, 2 years, in order really to define very well the conversion from the MCI to the AD disease, beta or no beta positive?
In Santander?
In Santander.
Yeah, I think this have been followed for 4 years, more or less.
4 years?
Yeah.
Because your sample is quite nice, it's a number.
Yeah, but the thing is that it's just preliminary study and it's cross-sectional, so we have to do a longitudinal study to see how things end up, and also include autopsies as we did in UCSF to see in the end who had the reason, the clinician or the pet.
Because the only problem to accept or to concrete very well the positive A beta in the PIP is to define very well the concept of the amnestic MCI versus the multi-domain.
Definitely.
And that is really the difference from this sample. Thank you very much.
Yeah.
It's a beautiful review. Thank you.
Thank you.
Well, thank you very much. We have to move to the next.